Hello everyone, now let us discuss about 2023 ICD 10cm coding guidelines for chapter 19, which covers injury, poisoning and certain other consequences of external causes. In the part 1, we will be discussing mainly about how to code traumatic fractures. Now coming to the various guidelines that are covered under chapter 19 are, the first one is application of 7th character in chapter 19 codes. This we will cover in this session. Next is coding of traumatic fractures. Even this will be covered here. The next guideline is coding of injuries, coding of burns and corrosions, adverse effects, poisoning, underdosing and toxic effects, adult and child abuse, neglect and other maltreatment, complications of care. These are the various guidelines that are covered under chapter 19. Now coming to the first guideline, application of 7th character in chapter 19. Most categories in chapter 19 have a 7th character requirement for each applicable code. They have a 7th character requirement. And in most categories, there are mainly 3 majorly used 7th characters, A, D and S, for majority of the injuries. There are other classifications also which we will discuss in the fractures. As of now, most categories in chapter 19 have 3 7th character values, with the exception of fractures. A for initial encounter, D for subsequent encounter, S for sequela. These are the major 3 7th characters that are mostly employed. Next, categories for traumatic fractures have additional 7th character values. While the patient may be seen by a new or different provider over the course of treatment for an injury, assignment of the 7th character, whether this is important, whether the patient is being seen by a new physician or same provider or different provider or new physician. 7th character is based on whether the patient is undergoing active treatment or not. Simply, the 7th character is based on whether the patient is undergoing active treatment or not. Until the active treatment is going on, you need to employ only A. After the completion of active treatment for routine follow-up, you need to code D, subsequent encounter. And if there are any late effects or sequelae, then you need to code S, 7th character. So depending upon the active treatment, if the patient is undergoing active treatment, then you need to code A only. Even though if it is an existing provider or a new provider, that is irrespective. Until and unless active treatment is going on, you need to provide A only. After the completion of active treatment, you can code D, subsequent encounter. Now let us discuss about fractures. Generally, the code assignment is based on various factors. First one is type of fracture. For example, whether it is comminuted, spiral, segmental, oblique, transverse or green stick. The next is anatomical site. We'll check for the anatomical site. For example, whether it is ankle, foot, hand or wrist. The next, we will check whether it is displaced or non-displaced. The next is whether it is routine healing or delayed healing. Next, if there is any malunion or if there is any non-union. And along with the anatomical site only, you will check the laterality, whether it is right or left. And finally, type of encounter, whether it is initial, subsequent or sequel. There are other 7th character values that we will discuss now. So these are the various governing factors that are taken into consideration before coding fractures, traumatic fractures in specific. Now coming to the general 7th characters to govern the type of encounter for fracture. A indicates initial encounter for closed fracture. B indicates initial encounter for open fracture. D indicates subsequent encounter for fracture with routine healing. And G indicates subsequent encounter for fracture with delayed healing. K indicates subsequent encounter for fracture with non-union. P indicates subsequent encounter for fracture with malunion and S indicates sequela. These are the appropriate seventh characters that must be assigned to fracture codes depending upon the scenario, that is type of encounter. Now coming to open fractures. Open fractures are categorized by Gustilo classification. Based upon the mechanism of injury, damage to soft tissue and degree of skeletal involvement, the Gustilo classification categorizes open fractures of the extremities into three main classes: class 1, class 2, class 3, with class 3 further subdivided into A, B and C. These are the based upon the mechanism of injury, damage to soft tissue and degree of skeletal involvement. Gustilo classification categorizes open fractures into mainly three classes. Class 3 again is subdivided into A, B and C. Coming to class 1, the definition is low energy wound less than 1 centimeter. Coming to class 2, wound greater than 1 centimeter with moderate soft tissue damage. Coming to class 3, high energy wound greater than 1 centimeter with extensive soft tissue damage. Coming to subcategories of class 3, 3A, class 3A indicates adequate soft tissue cover, class 3B indicates inadequate soft tissue cover, and class 3C indicates associated with arterial injury. Whenever an open fracture is associated with arterial injury, it comes under class 3C. Now, ICD-10 code set provides 7th character extensions to designate the specific type of open fracture based on Gustilo open fracture classification. This is applicable to fractures of forearm, which comes under the category S52, fractures of femur, which comes under the category S72, and fractures of lower leg, which comes under the category S82. Prognosis is determined by the Gustilo classification as it identifies the severity of the injury based upon the soft tissue damage and correlated to healing as well as infection and amputation rates. One important guideline is if a fracture is unspecified in terms of displaced or non-displaced, then ICD-10 guidelines requires default coding of displaced fracture. Whenever it is not mentioned whether the fracture is displaced or non-displaced, by default you need to code displaced. And if it is not mentioned whether the fracture is open or closed, then you need to code by default closed fracture. By default displaced, by default closed. Whenever it is not mentioned displaced or non-displaced, you need to code displaced. Whenever it is not mentioned opened or closed, you need to go for closed type. This is the ground rule. Now coming to 7th character extensions based on the Gustilo open fracture classification. B. 7th character B indicates initial encounter for open fracture type 1 or 2. Or open NOS. That is why in the previous slide we have discussed B. B indicates, 7th character B indicates initial encounter for open fracture 1 or 2 or NOS for open fracture. Next, 7th character C indicates initial encounter for open fracture type 3A, 3B or 3C. For class 3, you need to code C as initial encounter. And E indicates, 7th character E indicates subsequent encounter for open fractures type 1 or 2 with routine healing. 7th character F indicates subsequent encounter for open fractures type 3A, 3B or 3C with routine healing. 7th character H indicates subsequent encounter for open fractures type 1 or 2 with delayed healing. Next, J indicates subsequent encounter for open fractures with type 3A, 3B or 3C with delayed healing. So delayed healing is given by 2, 7th character H and J, whereas routine healing is given by 7th character E and F. Next, coming to 7th character M, subsequent encounter for open fracture type 1 or 2 with non-union, whereas N indicates subsequent encounter for open fracture, type 3A, 3B or 3C with non-union. Finally, Q indicates subsequent encounter for open fracture type 1 or 2 with malunion, and R indicates subsequent encounter for open fracture type 3A, 3B or 3C with malunion. These are the various 7th character extensions for coding open fractures based on Gustilo open fracture classification. Now coming to general coding guidelines for traumatic fractures. Fractures are coded individually by site according to provisions in the categories of codes codes of block S and details furnished in the medical record. They come under the category S codes. And multiple fractures are sequenced based on the severity. Whenever multiple fractures are present, you need to sequence the severe fracture first. They are sequenced based on severity. And traumatic fractures are coded with appropriate 7th character for initial encounter. It can be A, B or C while the patient is receiving the active treatment. A indicates initial encounter for closed fracture and B and C we have discussed earlier. They indicate initial encounters for different types of open fractures. Now the appropriate 7th character should be assigned for patients seeking delayed treatment or non-union. Complications such as malunion or non-union should be coded with appropriate 7th character. Designated for subsequent care of non-union, it can be either K, M or N, or subsequent care for malunion which indicated by PQR as we have discussed earlier. And if the patient has, this is also important that we have discussed this point while we are talking about chapter 13, musculoskeletal system. This is also musculoskeletal system. If the patient has osteoporosis that results in a fracture from a minor fall which would not normally break a healthy bone, a code from category M80 should be coded, not traumatic fracture. Once the patient has osteoporosis and that results in fracture from minor fall, you need to code from category M80, not the S codes. Next, finally coming to complications. Complications arising from surgical treatment of fractures during the healing or recovery phases should be coded with appropriate complication codes. And for complication codes, active treatment refers to treatment for the condition described by the code, even though it may be related to an earlier precipitating problem. This is important. For complication codes, the active treatment refers to treatment for condition described by the code, even though it may be related to an earlier precipitating problem. For example, code T84.50XA indicates initial encounter, infection and inflammatory reaction due to unspecified internal joint prosthesis initial encounter is used when active treatment is provided for the infection, even though the condition is related to prosthetic device that or implant or graft that was placed in the previous encounter. Here A is indicated for the active treatment of infection, though the infection is caused due to prosthesis which was placed in the earlier encounter. So for complication codes, active treatment refers to treatment for the condition or the complication described by the code, even though it may be related to an earlier precipitating problem. Now 7th character A, initial encounter, is used for each encounter where patient is receiving the active treatment for the condition. This is clear. Whenever the patient is receiving active treatment, A for active. So you need to code only 7th character A. And the 7th character D, subsequent encounter, is used for encounters after the patient has completed the active treatment of the condition and is receiving care for the condition during the healing or recovery process. And aftercare Z code should not be used for aftercare conditions such as injuries or poisoning. This is also important note. The aftercare Z codes should not be used for aftercare for conditions following an injury or poisoning. 7th character, appropriate 7th character should be coded. For example, for aftercare of an injury, assign acute injury code with 7th character D, subsequent encounter, and 7th character S. Sequela is used for complications or conditions that arise as a direct result of the condition, such as scar formation after a burn. Scars are sequelae for the burn. This is important. Scars are sequelae for the burn. Whenever scar is present, you need to code S, sequelae of that particular burn code. When using 7th character S, it is necessary to use both the injury code that precipitated the sequela and the code of the sequela itself. That is, late effect should be coded, also injury code with S character. And S is added only to the injury code, not the sequela code. When using 7th character S, it is necessary to use both the injury code that precipitated the sequela and the code for sequela itself, and S character is only added to the injury code, not the sequela code. And 7th character S identifies the injury responsible for the sequela. And specific type of sequela, for example scar, is sequenced first followed by the injury code. The late effect should be sequenced first followed by the injury code with S character. Now coming to coding of traumatic fractures guidelines. The first guideline is regarding when must we use initial versus subsequent encounter of fractures. The next one is multiple fracture sequencing, and finally Physeal fractures. The principles for multiple coding of injury should be followed in the coding of fractures. And the fractures of specified sites are coded individually by site in accordance with both the provisions within the categories S02, S12, S22, S32, S42, S49, S52, 59, S62, S72, S79, S82, S89, S92, and the levels of detail furnished in the medical record content. And one important ground rule that we have discussed earlier, a fracture is not indicated as open or closed should be coded as closed, and a fracture not indicated whether displaced or non-displaced should be coded as displaced. So by default closed must be coded and by default displaced must be coded whenever there is no specific documentation. And more specific guidelines are as follows. The first one is initial versus subsequent encounter. When must we code initial encounter? Traumatic fractures are coded with using appropriate 7th character for initial encounter A, B or C for each encounter when the patient is receiving active treatment. A for active, A, B, C all must be coded depending upon the type of the fracture when the patient is receiving active treatment. Whenever patient is receiving active treatment, then only you need to code initial encounter. And the appropriate 7th character for initial encounter should be assigned for a patient who delayed seeking the treatment for the fracture or non-union. And fractures are coded using appropriate 7th character for subsequent care for encounters after the patient has completed active treatment of fracture and is receiving routine care for fracture during the healing or recovery phase. In simple terms, initial is coded whenever active treatment is going on, and subsequent codes, subsequent 7th character codes with routine healing are given for general follow-up. And if there is any malunion or non-union, then you can use appropriate 7th character based upon the documentation. And whenever we are coding complications, care for complications of surgical treatment for fracture repairs during the healing or recovery phase should be coded with appropriate complication codes. Whenever complications arise, we need to code appropriate complication codes. Care of complication of fractures such as malunion or non-union should be reported with appropriate 7th character for subsequent care with non-union. It can be K, M or N, or for malunion it can be P, Q or R based upon the type of fracture. Coming to malunion or non-union, the appropriate 7th character for initial encounter should also be assigned for a patient who delayed seeking treatment for the fracture or non-union. This is important. Patient has undergone an injury but he delayed the treatment. Because of delaying the treatment, if malunion or non-union occurs, appropriate seventh character for initial encounter should also be assigned for a patient who delayed seeking treatment for the fracture or non-union. And the open fracture designations in the assignment of seventh character for fractures for forearm, femur or lower leg including the ankle are based upon Gustilo open fracture classification. This is just a point. We have discussed in detail about the Gustilo classification. So the open fracture designations are different. They have different seventh character values, which mainly involve the fractures of forearm, femur and lower leg including the ankle, and they are based on Gustilo open fracture classification. When Gustilo classification type is not specified for the open fracture, seventh character for open fracture type 1 or type 2 should be assigned. This is important. There are in total 3 classes and third class is again subcategorized into A, B and C. And whenever Gustilo classification type is not specified for open fracture, seventh character for open fracture, it can be type 1 or type 2 should be assigned. By default, you can go type 1 or type 2, not type 3. And a code from category M80, not a traumatic fracture code, should be used when any patient with known osteoporosis who suffers a fracture, even if the patient has minor fall or trauma, and if the fall or trauma would not usually break a normal healthy bone. And aftercare Z code should not be used for aftercare of traumatic fractures. For aftercare of traumatic fracture, you need to assign the appropriate seventh character. Coming to multiple fractures are sequenced in according to the severity of the fracture. Most severe fracture is sequenced first, followed by less severe fracture. Coming to Physeal fractures. Here we will discuss in detail about the Physeal fractures also. For Physeal fractures, assign only the codes identifying the type of Physeal fracture. Do not assign a separate code to identify specific bone that is fracture. You have specific codes for Physeal fractures. Whenever coding this Physeal fracture, you need to use those codes only, not other codes. Now let us discuss about Physeal fractures. Now coming to Physeal fractures. What are Physeal fractures? They are also referred to as growth plate fractures. Physeal fractures are growth plate fractures are the fractures that occur in the distal or proximal physis of the long bone, and they are of particular concern when occur in children and adolescents who do not have finished growing. Until full growth is attained, the growth plates are open and filled with cartilaginous tissue. And when a physeal fracture occurs, the cartilaginous tissue of the growth plate becomes disrupted or separated, and when this occurs, bone growth may be affected. So these are particularly important in children and adolescents. In the United States, the physeal fractures are classified by severity using a system developed in 1963 by Robert Salter and W. Robert Harris. And the system is known as Salter-Harris classification system. The physeal fractures are based upon the classification developed by Salter and Harris, and it is called as Salter-Harris classification system. Now, before going into physeal fractures, let us briefly discuss the anatomy of long bone. Bone will have these parts: diaphysis, epiphysis, physis and periosteum. Diaphysis is also called as the shaft. This is the middle section of the long bone and it is composed of compact bone tissue. Coming to epiphysis, each long bone has two epiphyses, one located at the proximal end and other located at the distal end. And the epiphyses are composed of spongy bone that contains bone marrow. Coming to physis, the physis also referred to as growth plate. Physeal epiphyseal plate or epiphyseal cartilage. Physis is also called as growth plate, epiphyseal plate or epiphyseal cartilage. This is the cartilaginous region between the diaphysis and epiphysis where the bone growth occurs. And physeal fractures, they occur in this area only. Hence the name physeal fractures. Coming to periosteum, the dense white fibrous membrane that covers the external surface of the bone. And some Salter-Harris fractures involve only physis, while others extend into epiphysis and or diaphysis. This is also important. Some Salter-Harris fractures involve only physis, hence the name physeal fracture. But while others extend into epiphysis or diaphysis also. Now coming to the types of physeal fractures. The physeal fractures are classified into 9 types using Salter-Harris classification system. The types 1 to 4 are most common and characteristics of these 4 types are as follows. All the types are covered here, all 9 types. Coming to type 1. Fracture of the bone through growth plate with separation of epiphysis from the diaphysis. Coming to type 2, fracture of bone through the growth plate and a portion of the diaphysis without the fracture of epiphysis. Coming to type 3, fracture through the growth plate and epiphysis and a complete break through the epiphysis. Type 4, fracture through diaphysis, growth plate and epiphysis. Type 5 to 9 are less common types of physeal fractures and have the following characteristics. Coming to type 5, this is a crush or compression type injury that involves only the growth plate without the fracture of either diaphysis or epiphysis. Coming to type 6, it is a rare injury involving perichondral structures. Perichondrium is the connective tissue membrane that surrounds the cartilage. Coming to type 7, it is an isolated injury of the growth plate. Coming to type 8, an isolated injury of the metaphysis with potential complications related to endochondral ossification. Endochondrium is the intracartilaginous tissue. Coming to type 9, finally, an injury to periosteum with the potential to interfere with membranous growth. These are the various types of physeal fractures according to the Salter-Harris classification system, and type 1 to type 4 are most common. Now coming to the 7th character for physeal fractures. A indicates initial encounter for closed fracture. D indicates subsequent encounter for fracture with routine healing. G indicates subsequent encounter for fracture with delayed healing. K indicates subsequent encounter for fracture with non-union. P indicates subsequent encounter for fracture with malunion, and S indicates sequela. It should be noted that there is no 7th character extension for an open physeal fracture, as Salter-Harris classification relate to closed injuries of the physis. This is important. It should be noted that there is no 7th character extension for an open physeal fracture, as Salter-Harris classifications relate to only closed injuries of the physis. Now let us discuss some of the examples regarding to physeal fractures. The first question is initial encounter, Salter-Harris type 2 physeal fracture of distal femur, right femur. The appropriate code is S79.121A. Salter-Harris type 2 physeal fracture of lower end of right femur, initial encounter for closed fracture. Next question, follow-up care, Salter-Harris type 3 physeal fracture of distal left femur with non-union. The appropriate code is S79.132K. Salter-Harris type 3 physeal fracture of lower end of left femur, subsequent encounter for fracture with non-union indicated by 7th character K. Next question, partial growth plate arrest of distal right femur following traumatic Salter-Harris fracture. Salter-Harris type 2 fracture of distal femoral epiphysis, sustained 1 year ago. So here there is a sequela, that is partial growth plate arrest. So first sequela code should be coded M89.157, partial physeal arrest, right distal femur. Next, followed by injury code S79.121S with 7th character S. S79.121S. Salted Harris type 2 physeal fracture of lower end of right femur, sequela. Now let us discuss one more example. A patient with a previous trimalleolar fracture of the left ankle is seen for increased pain and is found to have malunion upon evaluation. The diagnosis code in this case would be, here first we need to check whether the type of the fracture is mentioned or not. Here location is mentioned, trimalleolar fracture of left ankle, but it is not mentioned whether it is open or closed. So by default you need to code closed. And second, it is not mentioned whether it is displaced or non-displaced. So by default you need to code displaced. So the appropriate code for this scenario is S82.852P. Displaced trimalleolar fracture of the left lower leg, subsequent encounter for closed fracture with malunion indicated by 7th character P. Because the type is not mentioned whether open or closed, we have gone for closed fracture. And because it is not mentioned whether it is displaced or non-displaced, we have gone for displaced by default. Now let us discuss one more example. A patient visits the radiology department for an X-ray following a displaced closed fracture. Here the physician documents the type, displaced and closed fracture of the greater trochanter of right femur. And the diagnosis code in this case would be S72.111D, displaced fracture of greater trochanter of right femur, subsequent encounter for closed fracture with routine healing. By this, we complete the coding guidelines for traumatic fractures, part 1 of chapter 19. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.